I think your issues related to the Hispanic health perspective is a very important issue for minority people. It may be also existing in different developing countries, especially Southeast Asian countries. But when you look at the health status among the different minority groups in Bangladesh, we found like some minority groups' health status is better than the slums people. I don't know that how you are going to define this slum people status, compared to minority groups within a same geographical areas. Then when you look at the globally, the people from different countries, those are migrating in developed countries for their livelihood. That's one of the classical example of a presentation, and thanks for this presentation. I think for all developed countries, we need some sort of strategical perspective how they are going to tackle the migrant people health perspective issues, because they are one of the major workforce, and there is a global perspective we need to consider for ensuring their health status, which can ensure their better outcome in terms of their working capacity, production perspective, and contribution of a developing country persons in a developed countries economic issues. It's a problem related to the local to global perspective, but this is a very, very important issues. Especially, I think our country like Bangladesh, whose main income is coming from the immigrant people, or those are working in the different Middle East countries. And when I look at their health status, we found there is a very vulnerable perspectives, as they are giving their whole life doing the job in the abroad, sending the money to the home countries, and when they become old, they come back and they die. In terms of health, our developing countries need some sort of strategy, how we can really make a good health services for them, as well as when they are working in the abroad, how they can get a better health services. I think in that perspective, George is going to talk about the engaging urban slum communities for the prevention of chronic diseases. And he's from Abbott Association. Abbott has a large-scale services all over the world. They have a program in different countries. Maybe he will going to talk about this whole perspective related to the local slums people and the people those are working in abroad, what type of strategy we need. George.
It's to be here. Thank you, Dr. Shamim, chairperson of this session, Dr. Riaz, Dr. Hussain, honored delegates. My name is Uman George. I work with Abt Associates. As Shamim said, we work in several countries, over 45 countries across the world. We are a US-based company working in the development sector. Health is one of the areas that we work in. We also work in education, climate change and environment, agriculture, food security, and so on. What I'm going to talk about is about engaging urban slum communities. Most of you would have heard this idiom, a chain is as strong as its weakest link. I truly believe that when it comes to health, we have some weak links. To me, when it comes to developing countries especially, there are two primary weak links. The first is a very large set of communities who live in overcrowded setups, which often are called informal, but they're not necessarily informal. We call them urban slums. The second weak link in our health system is the attention that we give on prevention. I'm going to draw heavily from a very recent experience that we had, where we engaged urban slums in the state of Karnataka, which is in South India, and it was a tuberculosis prevention and care initiative. However, most of what I'm going to say is about engaging the slum communities and providing care and support to people affected by TB. But that does not mean that this is limited only to a disease like TB itself. I'm sure this can be taken across to other areas of health, especially the NCDs, for HIV, and possibly even for maternal and child health. This is a very unusual map. Some of you may have seen this, some of you may not. It shows the world, how the world would look if instead of the geographic area, we were to take the incidence of tuberculosis. As you can see, most of the large countries here are stretching from Eastern Europe to South Asia, to Southeast Asia, and to, you can see that most of the African countries are also pretty large. So it's just an indication of what the burden of disease is in these countries. The thing about tuberculosis is that there is a very high incidence in poor countries and in the countries in poor communities. India has an incidence of 171 TB patients every year per 100,000 population. I think the presentation has gone off.
Sorry? এই সেশনটা শুরু হলে রিফ্রেশমেন্ট থাকবে কিন্তু একটু বোধহয় এর আসতে দেরি হবে
I'm going to carry on. I don't know if somebody is adjusting the getting the technology back, but I'm going to carry on, so you know, in the interest of time. What is really scary about TB is not just about the size of the problem. Till now we felt we could address this quite easily. Globally as well as in India, 1 of 3 people with TB are considered missing. What does missing mean? It does not mean that we don't know about them. It does not mean that these people are not getting treated. They probably are. Most of them are actually being treated, but usually in the private sector, and we don't know about them. We don't know what quality of diagnosis is used to diagnose them, what is the quality of treatment, whether they are being followed up, and how many of them are actually completing their treatment. What's become urgent about tuberculosis is the growing threat of drug-resistant TB. In some parts of India, this is a major scare, and we are facing huge percentages of populations with drug resistance. For those of you who understand TB, you'll realize that factors or characteristics of urban communities, especially urban slum communities, tend to predispose to increased infection or increased rate of spread. So, people in urban slums are highly vulnerable to TB and to several other diseases. When we look at urban slums, they are different from city to city. For example, a large city like Mumbai or possibly even Dhaka, New Delhi, they have very different characteristics from those of a smaller town or a smaller city. The micro-populations are more diverse. In Mumbai, for example, you'll actually have very large subpopulations of Biharis or Punjabis or Tamilians or Bengalis, not just Marathis. But if you look at a town in, say, Karnataka, say Hubli, you'll have the difference between the micro-populations may be less stark, but they're equally important. However, irrespective of the city that you're looking at, there are some characteristics which are common across urban slums all over. And this would be common across countries too. Overcrowding, poverty, poor sanitation, malnutrition. Stigma is a huge issue when it comes to TB. Most people, relate stigma to diseases like HIV, but TB has tremendous stigma associated with it, and that impacts health seeking, and it impacts prevention, and it impacts health delivery and care and support. Migration is another big problem that affects populations with TB. So urban slums are often filled with people or have a lot of people who are migrants. And what's interesting is that because of its own nature, both public or private healthcare services do not reach urban slums adequately. There's very low reach of healthcare services. As a result of these problems, there are several consequences. There's increased spread of the disease, there's higher incidence because of overcrowding, because of nutritional issues. There is delay in health seeking, which in turn results in delays in diagnosis and treatment. There's poor treatment outcomes due to very poor care and support systems. I'm going to detail this in a little more in the coming slides, so I'm not explaining them further. As far as the solutions are concerned, it's fairly straightforward. We need to increase the demand. We need to improve health seeking through better dissemination of knowledge and awareness, improving awareness. Not just that, we also have to empower people to reach the health services that are standard. It's not just enough to get people to go to these services or to these facilities. It's equally important to balance the coin. The other side of the coin is the health delivery. So to prevent spread, we need to carry out a lot of education. We have to improve diagnosis. We have to do a lot of contact tracing and screening and provide care and support. So health delivery needs to be matched with health seeking, with emphasis on health seeking. The Strengthening Health Outcomes Through the Private Sector is a USAID-funded project which is implemented across several countries. In India, we worked on several different models, and tuberculosis was one of them. Our focus in TB prevention and care was carried out in the state of Karnataka in 42 towns across 663 slums. We covered a population of 1.1 million people. We did not look at any one population group. We looked at this from a comprehensive perspective. We put the patient in the middle and we said, okay, who are the stakeholders that the patient relates to? Firstly, there's the community from which he or she comes from, the families to which they belong. The two major sectors influencing healthcare, the public and the private ones, we all know that. What many of us often assume is that the urban poor, especially those in urban slums, tend to go to the public sector. That's not true. About 4 years ago, we had conducted a couple of studies in two very different states. You would have heard of the state of Uttar Pradesh in North India and Karnataka in South India. In North India, among those who went to any provider, 75% of them went to the private sector. In the south, in Karnataka, of those who went to any provider, 55% of them went to private providers. So engaging the private sector is possibly even more relevant when it comes to engagement of urban slum populations. And we know why they go there. It's not just about, it's economic to some extent. If I'm a daily wager, I don't want to miss the opportunistic costs of going to the public sector, usually too heavy. So it's cheaper for me to go to someone who's local and from whom I can get healthcare fairly quickly. It's also about availability and access. They're usually available in places and at times which is convenient for the health seeker. So while these relationships were loosely held between the communities or the patients and the service provider, there was no link between the two sectors themselves. So what we did was we created a civil society-based interface agency which brought the three key stakeholders together to provide the comprehensive prevention and care services that were required. I'm going to talk about 5 steps that we used. Excuse me a minute. These are not written in stone, but they come from a lot of experience working with the elderly, working with HIV populations across various parts of India, and with working with tuberculosis over the last 12 years. But what we did was, we identified these steps, and then we addressed it in a comprehensive manner, keeping the patient in the middle. The first thing we did was to identify and map urban slums. I'm not getting into the details because I'm going to explain each of these in the next 5 slides. The second was to develop communication tools and messages which would be appropriate to people in the urban slums. The third was to influence behavior change among urban slum residents. This is to enable health seeking. And as I said earlier, we need to match health seeking with health delivery. So it was equally important to engage and build the capacity of healthcare providers. Our focus under shops was to engage with the private sector. As many of you know, India already has a fairly well-functioning national tuberculosis program, which manages about 55–60% of TB patients. And the private sector has been loosely engaged, but inadequately so. And the final step was to ensure care and support for treatment follow-up and for prevention of spread of TB. First step, to identify and map urban slums. Very simple process. As you see is a hand-drawn map of a city. And what you can't really appreciate very much in this diagram is that there are slums marked there. This is hand-drawn for a certain reason. It's drawn by the program manager who's responsible for that particular city, and just by doing it by hand, it's greater involvement. It's not like taking a map and saying, okay, I have a map. It's being involved from the first step onwards. So to identify and map, the first thing is to actually identify the slums. So where do you begin? Most towns, most cities have municipal lists. There are lists of slums with their populations, and they're usually based on the last census that was taken. But that's not enough, because many slums are actually not even documented anywhere. So what our teams did was, we did a drive around. A drive around is literally that. You know, 2 people sit on a motorcycle and they go around the city, they cover all the streets and roads and actually mark out the slums. The ones which are listed are then ticked off, and the ones that are not are added to the map. The second thing that we did was actually put those slums down into the city map. Once you've done that, you need to get into the slums. You can't do that without meeting with the key influencers or the key opinion leaders. Now, this is important. Now, who is an opinion leader? They could be politicians, but they're usually not just politicians. They're far more than that. They could be local councillors. They could be shopkeepers, health workers who are already been there, leaders of self-help groups, of youth clubs, and so on. The number of key opinion leaders that we actually engaged with was tremendous. The next step was to identify and map the micro-populations in slums. As I mentioned earlier, micro-populations could be socio-culturally different. They could be people with different languages and different states, backgrounds. But they could also be, in a country like India, micro-populations are often related to caste, profession, economic well-being. There are usually, in the larger slums, you have concentrations of people who are poorer and those who are better off, even within the slum. But it's not just that, it's also when you go house to house, there are micro-populations within each family. Which are the houses with more elderly, with more children who are very young, pregnant women, for example. So you need to identify all these types of people who are especially vulnerable, who are more likely to be vulnerable, who are more vulnerable to diseases like TB. So when we detail the slum map, What you saw earlier was a map of the city which had the slums. Now each of the outreach workers actually then draw the map of the slum itself and mark out those points which are important. So you do a geography, layout, size, population of each slum. You understand and identify the socio-demographic characteristics. You identify the infrastructure. Where are the health points? Where are the social aggregation points where people get together, maybe a community hall or something like that? Where do people go to draw water or to, where's the water supply? So these are congregation points which are important to know. Is there any industry? What is that industry? Weaving, for example, beadie making. There's a lot of, there's some towns where there are stone quarry workers, and some of these professions are actually associated with greater incidence of tuberculosis. The second point was to develop communication tools and messages. So these could be above the line tools, it could be below the line. We worked with below the line tools, more of outreach based communication. We created posters, leaflets, brochures, banners and so on. So the first thing that we had to do was when we develop these communication tools, we need to make sure that we are catering to the socio-cultural diversity in the slum. We need to be sensitive to religious differences, to cultural differences, to language differences, and so on. It's very important to do that, otherwise, you're not just not getting through, but you could actually get kicked out and not be able to, do what you really intend to do. The use of evidence when we decide our communication message is very important. And this evidence needs to be locally derived. You can't take a message that's relevant for, say, Northwest India and apply that to Northeast India or, to another country even of the same profile. Let me give you an example. About 4 years ago, when we were carrying out a similar project in two states of Uttar Pradesh and Karnataka, we did a baseline consumer awareness and behavior study in both the states. In Uttar Pradesh, the recommendation was that we should address the risk. For example, the message we sent out was that if a person has persistent cough of 2 weeks or more, he or she should seek health care. And because many people did not go to qualified providers, the second message was that they should go to qualified providers with those symptoms. In Karnataka, on the other hand, people were already going to qualified providers, and they already understood that if they had persistent cough, they could have TB. So the message there was focused around demanding sputum microscopy or sputum test when they went to a healthcare provider. So that's what I meant by using evidence to decide on communication messages. We need to be cognizant of stigma and gender issues. There are a lot of these in urban slum populations. There's a lot of stigma. And there's a lot of holding back based on gender, age, and so on. Should you use peer educators or should you use interpersonal communicators? Slums are a mixed group of people. They are closed, many slums are closed hierarchical subsystems. So a typical closed hierarchical subsystem which would have a lot of stigma related to it would be groups of MSM or female sex workers or transgender groups, which is commonly seen in people who work in HIV are familiar with that. But slums they have those micropopulations with these closed subsystems or with a lot of stigma attached to them. To reach such people, it is better to use peer educators. They tend to communicate better in a manner that's more acceptable and more effective. However, they don't often conform to control measures. And the quality of the message itself may not be of the same standard as what was originally put out. But for slums, you probably need a mixed group because you're talking about a varied set of people. So peer educators with good, strong training on interpersonal communication are the type of people we used. And if stigma is not a big issue, and the characteristics of these closed hierarchical subsystems are not there, then it's probably better to use interpersonal communicators. The third step is to enable health-seeking behavior. We need to communicate through multiple platforms. We can't reach everybody using the same method. You can't go house to house and reach everyone. Also, it's sometimes good to reach the same people in different ways just to establish the message that you're trying to give and to reinforce that. Most of us need to be reminded, even if we are aware of what needs to be done. In addition to this, it's important to have some tools which actually help the consumer, the health consumers, to access health services. These could be in the form of referral slips, letters, vouchers, and so on. I mean, the fact is that, you know, the person who's not very confident goes to a new provider and says, here, I've got this piece of paper, it tells me to come here, and I'm coming here. Here I am. That really helps. For certain more vulnerable people, especially elderly, pregnant women and small children and so on, it's good to do a verbal screening at home itself before so that you can actually